تمام.
بسم الله الرحمن الرحيم. قبل تقديم الدكتور أحمد بحب أشكر إدارة المؤتمر، الأستاذ الدكتور حامد الخياط، الأستاذة الدكتورة سحر حسنين، الدكتورة هدى طموم، الدكتورة أمنية الرشيدي، أساتذتنا الفاضلين على دعوتهم الكريمة للحضور. والشكر الثاني لتقديم الدكتور أحمد بالذات، لأنه طبعا الدكتور أحمد دي يعني صديق عزيز وأخ عزيز، والحقيقه انا اتعلمت منه الكثير في كينج فهد ميديكال سيتي، يعني موسوعه علميه في البيدياتريك نيورولوجي، بروفيسور اوف بيدياتريك نيورولوجي والتشيف يونيفرسيتي اوف ميسوري كانساس سيتي سكول اوف ميديسن. مساء الخير يا دكتور احمد، ما اعرفش عندك الصبح تقريبا، صباح الخير بقى.
صباح الخير، السلام عليكم، ازيك؟ متشكر يا دكتور على المقدمه الجميله دي، ربنا يبارك في حياتك. انا اتعلمت من حاجات كتير، ربنا يكرمك يا دكتور. بسم الله الرحمن الرحيم والصلاه والسلام على رسول الله. السلام عليكم جميعا. اولا I'd really like to thank the organizing committee, the presidents of the conference. It's a true honor to be with such an esteemed group of child neurologists and neurologists as well as surgeons. Mashallah, I know a lot of people in the audience. I've learned a lot from many of them, and I know they have contributed significantly to the field of epilepsy and the field of child neurology. So it's a true honor for me to be here. So inshallah, today we'll talk about neonatal seizure semiology and neonatal seizure treatment. And as everyone knows, that's such a huge topic, and I'll try to do my best to cover it in a 40 to 45 minutes. But as everyone knows, it's a huge topic that some people will spend their whole life trying to understand or scratch the surface on how to best approach neonatal seizure and epilepsy. I would be remiss if I do not mention my mentors, who I learned a lot from, Eli Mizrahi, Peter Kellaway, and Richard Rockaby. And some of the videos I'm going to be sharing, actually, they belong to Eli Mizrahi, and I got to work with him during my training and my fellowship. Some are mine, some are his. So just for the sake of honesty of presentation, I have to mention that. So I'll go ahead and go over our objectives. So hopefully we'll go over the semiology. I will focus mainly on the epileptic types of neonatal seizures. As everyone knows, neonates are going to do so many different movements, and a lot of their movements are not going to be epileptic. It doesn't mean it's good news. A lot of times, kids with severe hypoxic ischemic encephalopathy, kids with kernicterus, kids with other types of movement disorders will do mimickers, or will do movements that are going to be very similar to seizures, yet the identification of those is going to be very important to make sure that the treatment as well as the diagnostic approach is appropriate. So in today's talk, I'm going to only focus on the epileptic semiology. I will briefly touch on neonatal seizure EEG and its different patterns. And as everyone knows, neonatal seizures are very, very unique when it comes to its presentation. Part of it because of the epileptic network spread. Part of it is because of the periodic depolarization shift that happens with spikes and with seizures in neonates that is completely different than it is in infants and children and in adults. So the presentation and even the spread as well as the evolution of a neonatal seizure is very different than anything else we see in other age groups. I'll briefly cover a diagnostic approach. How can we get to a better focused approach? Neonatal seizures can be very confusing, especially given the different etiologies and the different backgrounds. It can be very confusing trying to get to a diagnosis. So hopefully we'll try to put an algorithm. How can I get to the department in which the diagnosis belongs? Then I'll touch on treatment, then prognosis a little bit. I think it's very important to look at the epilepsy or the seizure age of incidence, or the incidence, how many new cases of seizures and epilepsy get added to the prevalence of epilepsy. And so we have two spikes. And the first one happens in the first 2 years of life, the one I'm pointing to here. And it's very important because early diagnosis, as we all know, will lead to better outcomes and will lead to better development. So the second peak doesn't come until the late 60s because of a completely different set of etiologies. So think of it as I have new incident. That means my prevalence will continue to get higher, And the less my incidence, the less my prevalence. So those kids who get seizures and epilepsy early on in the first 28 days of life, if I appropriately address it and I appropriately treat it, then I will reduce the prevalence of epilepsy, because those kids, as they get older to become 4, 5, 10, 20, 30 years of age, if I take care of their seizures and epilepsy early on, I am improving their development. I'm also improving their later likelihood of developing drug-resistant epilepsy and so on. So it is super important to address that. With all due respect to all epileptologists and all neurologists, epilepsy is considered a pediatric disease because the biggest incidence of epilepsy happens in pediatrics. The other later incidence happens in way later in life. So if we do a good job at the front end of epilepsy by the proper approach, proper diagnosis, and proper treatment, we can really significantly improve the curve and the prevalence of epilepsy. So here's the classification. By the way, this classification has not changed much. So as Volpe looked at it, as Mizrahi, as Daniel Glaze, as many people, and there have been multiple NIH grants trying to kind of look and address it. Even when the ILAE tried to do the reclassification, they tend to stay away from neonatal seizures because, again, it's its own beast, it's its own classification. So as I mentioned, I'm going to only focus on the epileptic or the seizure portion of the epileptic event. I will not touch much on the other automatism and the other non-epileptic. So we have the focal clonic, the focal tonic, myoclonic, spasms, the generalized tonic, which tend not to be an epileptic in nature in neonates, as well as the motor automatism, which also tend to not be epileptic in nature. And we'll go over videos of all of those examples to kind of highlight the movements and what does it look like. And I'm sure everybody in the audience have seen those, they know those, but we're going to try to kind of put them into buckets or into categories, so it'll become a little bit easier when it comes to diagnosing them. So whenever we have epileptic hypersynchrony, that's when seizures happen. I need that spark. I need those spikes or those periodic depolarization shifts, and I need that networking to allow me to have a seizure, to allow the neonate to have a seizure. So those are what happens in focal clonic and focal tonic. Early on, we do not have the network to mount a generalized seizure. We'll see some videos of movements that will look as if it's generalized, but electrographically, it cannot be generalized in that early age. Even if it can sometimes look on the baby, on the kid, to look generalized, there's no network to be able to allow that because of the myelination has been so premature at that point. We also have the hyperexcitability. So the hypersynchrony is one end, where I have that bad neurons or those bad guys that will get together to mount a seizure, but I also can have the hyperexcitability. And again, it can happen at different levels of the motor unit. If it happens in the cortex, we'll see the myoclonic seizures, as we'll see here in a minute, with the Odonnell syndrome, with the Dravet syndrome, with some of the other neonatal myoclonic epilepsies. But it can also happen at a lower level of the motor unit. And in that case, those are less likely or unlikely to be epileptic in nature, even though they can look very, very similar. Hence the importance of putting the whole picture together. What's my history like? What's my exam like? What's my EEG like? All of those are going to be important, because just looking at the event itself, I can get misled. I can get misdirected by just looking at a video or just looking at an event. Then, of course, the non-epileptic, as we agreed, those are reflex. A lot of times it's because of that brainstem release phenomenon. Kids with severe hypoxic ischemic encephalopathy, especially when we start having injury to the red nucleus, I lose my rubrispinal control. I lose my inhibition to my monosynaptic arc reflex. With the littlest movement, I'm going to start having those automyoclonus or those automatism. Okay. So why don't we go ahead and just jump into some of the videos, as we'll go over those types here in order. So let's focus on the focal clonic seizures, and we'll go over some videos and some classification for the three types of the focal clonic, which can be unifocal, can happen in a limb, arm or leg, can happen in the face, or can happen in half of the body. It can be multifocal and alternating, so it can alternate left to right. It can be bilateral synchronous, and again, this is different than generalized, as we'll see in the video. It can be migrating, and the very famous one is the malignant migrating epilepsy of infancy that we see, and I actually have an example of it here that I'll show to you in EEG as well as by video, as well as the axial clonic seizures. Okay, so let's go on to talk about the unifocal limb. So as you will see on that young man here, the video allows me to play it. Can you see the video? Is the video playing on your end, Dr. Huda or Dr. Ashraf?
It's not working, Dr. Ahmed.
It is working on my end. I'm not sure why it's
Yes,
not working.
but here on the screen is stable, is not working. Do you see it's moving?
Yeah, it's moving on my end. That's strange. I'm not sure what's going on. I know it's not on my end because I can see it moving here. That's interesting. Okay. Give me a second. Let me go out and back in, please. I'm not sure what's going on. I don't know why it's not showing. Give me a second, please.
Okay.
Yeah, I think hopefully that works.
Full screen. Full screen. مش هتحرك اصلا.
Okay, you see it moving now?
Oh, it's moving now. It's moving.
Okay, I'm not sure what happened. I had to come out and back in again, so sorry about that. So as you see in that young man here, you see this left upper extremity focal clonic unilimb. So it's happening only in one side. It's only in one limb, and this is actually what I mentioned earlier. Some of those videos are from that NIH that happened a number of years ago when I was doing my fellowship with Eli. So you look at, you even can find it with the EEG. You see that left upper extremity clonic movements. You do see some movements in that and the other arm. It's completely asynchronous. It's not epileptic in nature. It's very random. In that next baby, you do see those left frontal high voltage spike and wave, and you'll see very soon here the movement. And again, we'll talk a little bit about that. See that right arm clonic movement. But notice that the seizure started electrographically way before the clinical movement. It's all one limb. It's all happening in motion. It can be happening on the other side of the body, but if it's happening, it's compensatory movement. It is not part of the seizure. It is not epileptic in nature. So again, this is a focal clonic unilimb, or one limb only that's having where the seizures are happening. Next is unifocal facial. So it can happen in the face. And this is where you start seeing, in that young man here, you notice the eye, the left eye. He's doing all sort of movements with his arms, but it's the eye where the clonic movements are happening. So it's mainly where the eye is. The rest of the body is moving as a part of the spread or part of the compensatory movement, but the seizure itself is happening only in the face. So he has those clonic movements or clonic twitches over the left side of his face, and it's correlating with his EEG showing those left high voltage rhythmic buildup of spike and slow wave. And we'll focus specifically on the EEG to look at the different patterns that can happen in neonatal EEG with seizures. Hemiconvulsive, and that's a really interesting one because as you look at it, it's happening on the left side. You notice the right arm is not moving. You notice the right leg is moving. And again, that's the compensatory movements. The right side of the body is attached to the left side. So as the left side is moving, it's going to drag, it's going to move the right side with it. Even in the EEG, you do see that higher amplitude over the right side. So it is not generalized. So you do have bilateral spread, or you have more synchrony on the EEG rather than it being a generalized seizure. Same thing with that young man. It's hemiconvulsive happening on one side of the body, while the other side is doing the opposite movement. So it's compensating for that right side hemiconvulsive clonic movements, and the left side is only compensating for it or following what the right side is doing. So we're going down the list. So we went over the unifocal, happening only in one focus. We're going to go to the multifocal, and this can be alternating, as we all know. And I'll show you an example of actually two seizures happening at the same exact moment on EEG because of that multifocality. When you look at the EEG, you notice that it's actually more than one focus. So it's multiple foci as it's building up. The baby is currently not doing anything, even though the seizure is happening, and that's the importance of EEG, where I'll talk in a second here, how early detecting subclinical seizures improves outcome by over 76%. We have our own publications and our own papers, which really aligns with Volpe's papers, with Glaze's papers, that this hemi-alternating can actually get it better, or can get the outcome better for development as well as for later drug-resistant epilepsy development if I take care of that early on. Okay, moving down the list, we're still with the multifocal, the bilateral asynchronous. So it's happening on both sides of the body, and it's asynchronous. And notice that this is different than some of the videos I showed you just earlier. You notice that both sides are moving. They're moving each rhythmically, but each at a different frequency. This is different than the random movements that happened on the other side of the body. So again, as all of you can tell, this is not generalized because it's not exactly synchronous. Even though the right and the left side are moving, the right and the left side are having clonic movements, it is not happening synchronously, it's asynchronously. Why is that important? A, the rhythmicity of it tells me it's a seizure. B, the multifocality of it tells me there's multifocal involvement. And a lot of those babies have either severe hypoglycemia at some point that led to cortical damage, or hypoxic ischemic encephalopathy. Same thing. Look at that left and right. It's very rhythmic on each side, but it's asynchronous. It's not happening at the same time. And when you look at the EEG, you do see two seizures happen at the same time. So while it's happening on both sides of the body, but it's two separate foci, allowing this to create the bilateral, that's asynchronous movements over the left and the right side. Just looking at the EEG, it's horrible, really, really encephalopathic, very bad EEG. When you look at the baby, he does all sorts of different movements, but as you look at that right lower extremity, and also as you look at that left face, there is an asynchronous bilateral clonic movement. And now the right leg and the left leg, they're happening asynchronously. They're not happening at the same exact time. Migrating, that's usually bad news whenever it's ping-ponging between left and right, right and left. Usually we're dealing with some of the bad news, some of the metabolic, some of the genetic disorders, as we'll talk here in a second. But those are never good news whenever we see those migrating, as it starts migrating left to right. And it's different than a Jacksonian march, or different than a march, because again, that networking early on especially in preterm babies, they don't have the myelination to be able to mount a Jacksonian march or to even have a full bilateral tonic-clonic. Now, there's an exception for every rule. So yes, I'm sure some of us here sitting in the audience say, oh, you know what, but I saw a child that yes, and I've seen them too. But the rule is it's very unlikely for us to see that in a neonate, especially preterm baby. So that's how it migrates. It actually goes left to right or right to left, and this is when it's really probably the worst of all news, and that's in neonates. That's usually in epilepsy in general. Spasms is the worst of all the news, except in neonates. The migrating epilepsy is the worst of all news. It's worse than spasms, and simply because of the underlying etiology, it really signifies really irritable and really hypersynchronous and hyperexcitable cortex. So as you saw here with the left foot, and it'll soon migrate over to other parts of the body, to left and right, and that's, again, when it crosses the midline, that's the bad news, and it really signifies the hyperexcitability. More examples of the same thing, so just gonna skip that. So far, just to kind of review real quickly, we went over the unifocal with its 3 types. We went over the multifocal with its 3 types. We're going to go over the axial. So axial is a little bit tricky. So we all know that tongue movements in childhood epilepsy and in adult epilepsy is much less likely to be seizures, to be epileptic in nature. That's very different in neonates. So in neonates, the tongue protrusion or the tongue axial protrusion, that's typically a sign of seizure. And it's not the left to right movement, it's the protrusion. It's the outwards protrusion of the tongue. That's usually the form of axial seizure if it's going to happen. So if you'll notice in that baby, and again, all of those babies, if you look at the background, very suppressed background, you don't see the typical neonatal changes. See that tongue? And if you look at the EEG, you see that right hemispheric seizure building up. So that tongue protrusion is the most common form of axial seizures. Some kids can have some more axial in the form of facial, kind of more the chin quivering, but they will never have the axial and the trunk. So they're never going to have like an axial tonic or axial clonic movements over the trunk, because again, for this to happen, I need to be able to engage my anterior and posterior fasciculi. I need to engage my corpus callosum, at which point for neonates, they don't have that myelination yet. All right, we're still moving down the list. So we went over the clonic type of seizures. We're going to move over to the tonic. So the focal tonic, again, can be 3 types. Can be on the eye or the face, on the limb, or asymmetric hemiposture. So look at that baby. And again, I want you to take a look at the EEG. It's suppressed. It's encephalopathic EEG as the baby is having his lunch. And all of a sudden, he'll pause, notice that left eye deviation, the tonic eye deviation. And if you notice on the EEG, you see that build up over that right hemisphere with the theta rhythmic activity over that right frontocentral region. So tonic, ocular, and it takes a very good nurse or a very good parent to be able to notice those, because it can be, was he taking a pause? What's going on? And obviously that happens in addition to other symptoms. So in that young man, he's having that left arm clonic movements, but look at the eye. He's also got this tonic eye gaze. When you look at the EEG, he actually has both on both sides. So tonic ocular phase, we look at the clonic facial. This is the more tonic ocular seizure. So from a tonic standpoint, can be on the face or in the eyes. It can be in the limbs. So this is focal tonic posture. And it really is what it sounds like, this upper extremity posture. And again, as I'm looking at those, as I'm looking at the video, if a parent send me a video, a lot of times it's very, very not clear. So we're gonna have to put it all in context. Can I stimulate the baby? Can I get him out of that movement? If I change the posture of the arm, does it stop? What's the frequency of it? Does it happen as the kid is asleep? Does it happen in certain situations? So all of those are questions that will help me decide are those epileptic or non-epileptic. And of course, if I capture an EEG, that's the best, and that's the slam dunk that I can tell for sure is that epileptic or non-epileptic. Focal tonic asymmetric hemiposture. It's a mouthful, but it's exactly what it sounds like. So you see that focal is going to get stuck into a position. So look at the EEG, and again, you see that right hemispheric. And yes, you do see some clonic movements, but the hallmark of the seizure, it's that tonic posture of that on the right, on the left side of the body rather. So his body is actually contorted towards the right side because of the tonic tension of the left side of the body. And yes, you'll have a couple of clonic movements, but the hallmark of the seizure is actually that tonic phase. I will not show you videos. I know in a previous talk, I showed videos of all the different types of even the non-epileptic events in neonates. But because of the time and to go over treatment, I will not show the videos of the myoclonic seizures. I'm sorry, I will not show the videos of the non-epileptic myoclonic events. I will show it only of the myoclonic epileptic events. Myoclonics are probably the most confusing with neonates because it can be many things. Those random fragmentary movements. It can mean some lack of integrity of the motor unit. Can also be a seizure. So I need to put a lot of things in context to be able to tell what's going on. And of course, EEG is the hallmark that will always help me know if I can capture it on C. So look at the left hand because it's very quick, and it will be see that one quick twitch, and you do see the EEG correlating with it. It's focal myoclonic. If it's ever generalized myoclonic, it is very unlikely to be seizures, including in Odonnell syndrome, including in Dravet syndrome, or the severe myoclonic epileptic encephalopathy, which, as you all know, can certainly happen in the neonatal age. It will have a different EEG signature. It will be different in its presentation, and even it might look generalized. It is typically asynchronous. Spasms, either the flexor, extension, or most kids or most babies will have the combined. So in the neonatal phase, like we agreed, neonates are a different beast. They're completely, they didn't read the book. They follow a different type of epilepsy classification. So they typically have the mixed type of spasms. And again, for spasms, as everybody here knows, it has to have the two phases, the myoclonic/tonic phase. So it's a very brief myoclonic, followed by a brief tonic. Now, for spasms in general, I can have a more pronounced myoclonic than a tonic, or I can have more a brief tonic than a myoclonic. The EEG signature will look very similar. And I'm not talking about the interictal. I'm not talking the hypsarrhythmia or its 7 modifications or even a different pattern on the EEG. I'm talking about as the seizure is actually happening. Typically, I'll see that high voltage slowing with the intermixed spikes followed by the electrodecrement and superimposed beta activity. That's pretty much the hallmark that you'll see. It will be a little bit different in neonates, and that's probably the only one that will really rapidly spread because of the hyperexcitability and the brain in neonates, that it will look as if it's generalized. But I want to take a look at the EEG, and I'll show you some other EEG examples. There's actually a lag. There's a lag between the right and the left side of the brain. So look at that. It's typically does not see that. It was a little bit of lag between the left and the right side. And in neonates, it's less likely to happen in clusters. It's different than it is in older babies. So a spasm, and that's again, that makes it a little bit more tricky and a little bit more challenging for us, that in neonates can be only a single movement and it stops. Can it happen in clusters? Yes, of course it can happen in clusters. It actually happens in cluster about 8% of the time, while 92% of the time it's more likely to be a single spasm, not associated with a cluster. So this is kind of a quick review of what we talked about and putting the whole classification. That's the NIH classification that was done. And again, Mizrahi, Ashwal, and I had the honor to participate and be part of that classification way back in my old time. So you have the focal clonic, focal tonic, myoclonic spasms that we looked at. And again, for the non-epileptic types, a lot of the myoclonics, and again, this is because of that release phenomena we talked about, the inhibition release phenomena. the generalized, some of the motor automatism, the bicycling, the arm movements, the shivering. All of those are automatism that are less likely to be epileptic in nature. This is a list of etiologies. You're all very familiar with it. The hypoxic ischemic encephalopathy is the top of that list. I'm going to show you some percentages of that. So how do I diagnose? What's the diagnostic approach? It obviously varies by the history and by my clinical exam. What do I see? MRI is almost a must in those babies, even if I know what exactly happened in the perinatal period. If I know and I have a documented placental abruption, or if I have documented prematurity, so I need that MRI to allow me to correlate what's going on with what I'm seeing on the EEG. I purposely did not put the EEG here because it's actually it's a must in any neonatal seizure. Actually, it's a must in any seizure, period, especially in the neonatal age group. It would be best if I can prolong the seizure, prolong the EEG to capture some of the seizures. As everyone here knows, the ILAE requirement for an EEG is 20-minute artifact-free, except in neonates. I need an hour, and I need to capture all sleep-wake cycles. So hence, to be able to capture a lot of what the neonates can do, because neonates can be very tricky. They can show me a completely normal EEG, and all of a sudden they go into bad seizures with asynchronous EEG and losing all their neonatal EEG milestones and so forth. If I know of a history of an HIE, if my exam confirms it, I see the MRI. It's so I don't need obviously to get all the rest of the metabolic studies. If I don't have the history, my MRI is questionable, it doesn't correlate with the clinical picture that I'm seeing, that's when I go down the list for the other metabolic, some of the genetic and genomic studies, and obviously the family history here plays a role. There are special cases that we really try to get to as soon as we can, and those are the treatable/curable neonatal epilepsies, like the GLUT1 transport deficiency, the pyridoxine deficiency, the biotinidase deficiencies, some of the neurotransmitters like the methyl tetrahydrofolate reductase deficiencies. Those are types of neonatal seizures that we can make not just a huge difference, we can make a complete difference in the outcome of the baby by early diagnosing it and giving it the proper specific treatment. Everything else will be the same treatment algorithm, except those guys. So for GLUT1, I want to start that ketogenic early. For the biotinidase, I want to start that biotin, and so on and so forth. So for the methyl tetrahydrofolate reductase, I want to make sure that I'm giving my folinic acid, my Dept. So it's very important to actually know that. So I'm not, and I'm talking about myself here, I will not be able to detect it unless I'm thinking about them. So we all go through our diagnostic approach. Obviously, if it's an HIE, I'm not going to think of GLUT1 or biotinidase deficiency, but as I'm going down my list and as I'm looking and seeing the response to treatment, the baby is refractory, is drug resistant. I've tried my third medication. My MRI is not showing me an abnormality. The seizures are really, that's when I start thinking, okay, could it be a B6 deficiency? Could it be a biotinidase and so forth? Because this can actually be completely cured. I would be remiss if I don't mention early epileptic encephalopathies in a neonatal talk here. So as you all know, the two big famous ones are the severe infantile myoclonic epilepsy or severe myoclonic epileptic encephalopathy, Dravet syndrome, and the Odonnell syndrome, the early myoclonic epileptic encephalopathy. They both have a periodic pattern. The periodicity will be different, with a longer periodicity in the Odonnell syndrome than it is with the Dravet syndrome. So typically it's going to be that burst suppression with a periodic pattern, but the periodicity will be a lot longer with the Odonnell syndrome than it will be with the Dravet syndrome. And again, this is where genetic testing can be very, very helpful, either with the Odonnell syndrome, with the STBPX1 being the most common. And again, it can be other genes and other forms, but that's the most common. And obviously the SCN1A with the Dravet syndrome, even though, as you all know, there are some modifying genes. So having a negative SCN1A does not necessarily completely rule out my severe myoclonic epilepsy. And that's why I intentionally left the term Dravet off of the slide, because Charlotte Dravet described a very specific syndrome with the SCN1A. Now, we can have the same exact syndrome without the SCN1A, and yet the treatment is very similar because of that modifying gene that can live on another chromosome. Okay, so we want to treat what's treatable. The easy, low-hanging fruit, common, my glucose, my calcium, my magnesium, as I'm looking at my metabolic studies and I identify hypoglycemia, hypoglycemia, hypomagnesemia, and so forth with those doses that you all know very, very well. So I'm not gonna spend time going over the doses. You all know it better than I do. Then this is actually one of the oldest treatment algorithms. So I'm going to go over what's FDA approved. Then I'm going to go over what is not FDA approved. So diazepam and Kevin Staley from who's a really good friend of mine, a phenomenal neonatal epileptologist from Harvard, from Mass General. He has a lot of literature, and I'm going to be quoting some of his work here in preterm babies and the treatment. So diazepam is actually neuroprotective. So that's usually early on, right out of the operating room or right out of the delivery room. Typically, we start with benzodiazepines, and we go down that list. Benzodiazepines with those doses, phenobarbital, fosphenytoin, if not available, phenytoin. As you all know, the difference is going to be the rate. I cannot give phenytoin as fast as I do fosphenytoin, so I got to be careful. I got to look for the bradycardia and the hyperalkalinity and so forth with phenytoin. The non-FDA, which we all use, and it's kind of funny that we use the non-FDA over the FDA approved, the levetiracetam, the topiramate. There are actually a number of studies, and our group here, we published a number of papers on the neuroprotective effect of topiramate as a maintenance. Obviously, we cannot load with topiramate early on. Lacosamide, that's another one that we actually published quite a bit on. My group did early on. It's available in IV form. I can give it in a loading dose. I can maintain it to 6 milligram per kilogram. Vigabatrin, obviously, only in the spasms cases, so is the ACTH. What about the non-pharmacological therapy? So I'm going to go over some of what our group did and published. So this is one of our papers we published a few years ago, looking at ketogenic diet in infants and neonates. And this actually we did it using breast milk feeding, where we maintain babies on 3:1 to 4:1 ratio. Obviously, your GLUT1 transport deficiency, 100% seizure freedom, and those kids we follow them later on. If we take care of them in the neonatal age group, we published a follow-up actually that those babies had normal development with neuropsychological testing normal. We had 75% reduction in other forms, and obviously this is for the drug-resistant one. So once I fail that third medicine and I continue to have seizures, that's when we move on to some of the other non-pharmacological therapies. We published our experience with 8 cases that we took the baby straight to the operating room, and it was different reasons. Some were AVMs, some were focal cortical dysplasia. There were a couple of tuberous sclerosis that one of the tubers was really acting out. So definitely epilepsy surgery is an option in neonates. In our series, 100% of the babies who are not tuberous sclerosis maintain seizure freedom, and that's the nice thing about the plasticity. Even though we did do cortical stimulation, cortical mapping, just to make sure that we're not encroaching on aliquot cortex. The 2-year follow-up, those babies did not have any aliquot cortex dysfunction, so they continue to do really well after the resection. Neuromodulation, and actually I'm especially proud of that one paper. You see the very first name here, Ahmed Abdelmoity. So this is actually my very own daughter, who's alhamdulillah finishing med school now, and I promised I didn't help her with that. I was the senior author, but she's the one that did the work. We looked at neuromodulation in infants and in neonates. Again, those are non-resective candidates who failed 3 medications with 73% responder rate. So 73% of those babies achieved a minimum of 50% reduction in seizure. So we published that in Seizure a couple of years ago, and actually that led to further work that we're currently about to publish specifically in kids with Dravet as well as Dose syndrome early on in their neonatal phase. I know I'm getting over my time here, so I'll try to wrap it up. So what's my treatment algorithm? How do I approach neonatal seizures? So here's my treat metabolic causes, the obvious, my glucose, my calcium, my magnesium, and so forth. Levetiracetam or phenobarbital, depends on the baby. Now, I mentioned Kevin Staley a second ago, and I think it's important to mention him here. In preterm babies, I do have glycine receptor downregulation. What that means is that my phenobarbital, that's an indirect GABA working on my glycine receptor, I can downregulate the receptor by giving phenobarbital. So all of a sudden, my phenobarbital, that's an anti-seizure medicine, can become a proconvulsant in preterm babies under 36 weeks of gestation. So I got to be very careful using phenobarbital under 36 weeks of gestation. And I'm not saying it doesn't work, but it can actually provoke more seizures. So if you're given phenobarbital and then under 36 weeks and you're not seeing an improvement, or sometimes even you see worsening of the seizures, there you go. Here's your answer. And you probably know this. It's the downregulation of my glycine receptor. So I don't use any phenobarbital in any baby under 36 weeks of gestation. And as a matter of fact, I really try to, as much as I can, avoid, even in our center, in our treatment algorithm, and our practice parameters, I completely removed phenobarbital. I put it as a backup if all of the above didn't work. So phenobarbital, just simply because of its glycine downregulation here. Diazepam, we talked about it being neuroprotective. Fosphenytoin, if needed. And again, I always am thinking and looking at my GLUT1 transport deficiency, the biotinidase, the non-ketotic hyperglycemia, the methyltetrahydrofolate reductase, those curable or treatable conditions. Prognosis, this depends on the etiology, and also depends on how soon I intervene. So Volpe as well as Mizrahi looked at the effect of cooling in HIE babies. If you do the cooling, and with the cooling, I do bedside EEG monitoring, capturing my subclinical seizures, which happen in about 40% of babies who are being cooled with HIE. I will not see anything clinically, but I will capture it on my EEG. Capturing and treating those subclinical seizures improves my outcome by about 30%. And that means my development as well as my likelihood of becoming seizure-free. So that's huge. So my hypoxic ischemic encephalopathy, as I go down the line, the numbers change. So my hypocalcemia and my hypoglycemia, they typically do well. Again, it all depends on how soon I treat and how soon I intervene. I'm going to skip this for the sake of time. It's actually looking at the outcome. This is another work that I got to work on with Mizrahi, and again, looking at the outcome. What percent do not make it out of the NICU? With 28%, the abnormal neurological outcome. So as you can see, early outcome can be bad. It all depends on what do I do in the first 28 days of life. If I detect it and treat it properly, it's more likely to have a better outcome. Once again, I really appreciate the opportunity to come and be with friends and my professors. I learned from each and every single one, Dr. Omnia, Dr. Ashraf, Dr. Huda, Dr. Shura, many names in the audience I actually learned from. And I'm very honored to be with you here today. And thanks again for the organizing committee to invite me to be with you today.
Thank you very much. Thank you very much دكتور أحمد عبد المعطي. الحقيقة احنا مهما بنسمع منك المحاضرة دي ما بنملش، بنبقى عايزين نسمعها. أنا سمعتها قبل كده، بس كل مرة you are upgrading and giving more and more information. ما بنشبعش منها يا دكتور أحمد. Now the floor for question, please, دكتور.
طبعا as usual outstanding presentation دكتور أحمد، متعودين على كده من حضرتك. I have two questions, one regarding the diagnosis and the other regarding the treatment policy and approach. Regarding the seizure types, some authors linked certain seizure types to specific pathogenetic mechanisms and subsequently a specific etiology. The league in 2020 put another approach which is linking the seizure types to specific syndromes. So I would like to know, in your practice, you recognize the etiological background from the seizure types directly or through linking these seizures types to the new syndromes, especially the self-limiting neonatal seizures, which is new in the new classification. The second question regarding the treatment is, you mentioned after excluding metabolic errors, you go to levetiracetam versus phenobarbital. The last league guidelines put phenobarbital at the first because of its neurotropic effect at first indication, and then using other anti-epileptics like levetiracetam. Again, they put after levetiracetam the midazolam, but you put in your presentation the diazepam. And you know that diazepam is greatly lipophilic, and it will be redistributed again, and it will have long sedation action. Besides, it will be metabolized to this methyl diazepam, which have another long-acting mechanism. So why did you prefer diazepam versus midazolam, which is against the last league guidelines?
Yeah, as always, great question, Dr. Ashraf. So let me try to address the first question about the classification and the etiology classification. As we all know, and this is what's in the league, and I'm very, very glad and happy that the league started adding the etiologic portion in its classification, because it helps linking everything together. Seizures can be, and EEG as well, can be suggestive, indicative, or diagnostic. It's diagnostic in very few conditions, like in SSPE, for example, where yes, I can look at the EEG and I can diagnose SSPE just looking at the EEG. And everything else, it is suggestive or indicative. For example, when I have a kid with Lennox-Gastaut syndrome, multiple seizure types with slow spike, slow wave, as well as developmental impairment, I cannot make an exact etiologic diagnosis knowing the seizure type or looking at the seizure type. As we all know, and I'll pick Dravet syndrome as an example. Dravet syndrome typically happens with myoclonic seizures. All kids will have some focal seizures. They will have bilateral tonic-clonic. They can have atypical absence, and they can have multiple seizure types. So looking at the seizure type by itself is not going to give me the full picture. I cannot make a specific etiologic diagnosis by looking at the seizure type. I have to include the rest of the picture. I have to include the family history. I have to include the genetic results and studies. And I have to include also the age of onset. So Dravet syndrome is very unlikely to start occurring after age 1. So that's one of the criteria. So I have to put it all together. So looking at just the seizure type without my EEG, without the history, without looking at the MRI, I cannot make an etiologic diagnosis. I agree 100%. I'm not, I thanks for allowing me to clarify. I am not going against the ILAE, of course. But what I'm saying is, by itself, the seizure type, it cannot give me the full picture. I need other components to allow me to make the etiologic diagnosis, including the MRI, including the genetic, including the metabolic testings, and so forth. Regarding the treatment, yes. So, and that's why I put it in the slide, what's FDA approved, which also what the ILE is aligning with, and what is not FDA approved. When you, and I'm sure you know this very well, when you look at the literature as far as seizure outcome, treatment with levetiracetam as well as treatment with phenobarbital, the literature as it now is more coming with levetiracetam. The side effect, the glycine downregulation that I mentioned, is a lot less likely with levetiracetam than it is with phenobarbital. As far as efficacy, and there was actually a recent randomized study randomizing neonates in the NICU between phenobarbital and levetiracetam IV, and it was not a double blind. Obviously, it was not a placebo, but it was randomized. So I'm going to give those patients levetiracetam. I'm going to give those phenobarbital, and there was no statistical significance in the outcome. So they pretty much had similar outcome. Yet a significant less side effects in the levetiracetam arm, as well as I didn't need to worry about the glycine receptor downregulation. So, and I have to be clear, there's absolutely nothing wrong with phenobarbital. It's an approved treatment. It's a great treatment. It works, I have to say, as good as the levetiracetam from a side effect standpoint, and from a glycine downregulation. Levetiracetam might have an edge over phenobarbital, and that's why in my own center, That's how we prioritize it. But yeah, phenobarbital is an absolutely perfect treatment. As far as the diazepam and midazolam, so yes, we do use midazolam, but we use it never as a first or second line of treatment. So we use it as a drip. As you very well know, midazolam is the shortest acting benzodiazepine. So it has a half-life of about 4 minutes. So for me to gain that, and because of the lipophilicity of the diazepam, I want to take advantage of the longer half-life. I want to take advantage of the lipophilicity by making it a regimen treatment as opposed to a drip treatment. You're absolutely correct. When it comes to a drip, when it comes to when I need to do an infusion, it's absolutely midazolam. You're absolutely 100% correct. But I do that with continuous EEG. I will never hook a baby to midazolam drip without a continuous EEG, and that's what the ACNS recommends. That's what the ILE recommends. So, but for a regimen treatment, the diazepam longer half-life, the lipophilicity, the neuroprotective effect of the diazepam, and that's the work I just referenced by Elizabeth Thiel, by Kevin Staley and others. It is neuroprotective. That's why I can use it as a first line. If I need an infusion, that's when I fall back on the midazolam.
Thank you. Thank you so much, Dr. Ahmed, for the excellent presentation. I just have 2 questions. So the first question is, what's your practice for whenever you're suspecting pyridoxine-dependent seizures or pyridoxal phosphate-dependent seizures? So do you empirically start on, or I mean not empirically, do you start pyridoxine and then look at the EEG until you get the metabolic profile? The second question, you mentioned that infantile spasms typically have this, clonic or more tonic phase, but sometimes in older age group, especially, when they present at the age of 2 or 3, like epileptic spasms, how you differentiate them sometimes from myoclonic seizures, especially, that there are many patterns of the EEG. So typically, sometimes we don't find a pattern of hypsarrhythmia or modified hypsarrhythmia, and even sometimes we find a normal EEG. So how do you, because this is really challenging in our practice. Thank you.
No, I think those are great questions. Let me start with the second question first. So just to clarify, it would not be clonic in spasm. It would be myoclonic/tonic. So clinically, or looking at a video, having the tonic phase, and again, that's easy to detect from a video. So the myoclonic followed by the tonic. If it's only myoclonic without a tonic phase associated with it, I am thinking less likely spasms. What will really make the difference is having the EEG at the time of the seizure. To your excellent point, the EEG interictally can look anything. Can show the hypsarrhythmia, can show modified hypsarrhythmia, can show just epileptic encephalopathy. Early on, I might even see, even though it's very, very, very rare, but I might even see a normal EEG. But when the seizure actually happens, it will show me that high voltage, sharp and slow, and that electrodecamol with the beta, that's the tonic phase. The tonic phase can be a second or half a second, or it can be up to 3 seconds. So, and that's where the confusion can sometimes come. That tonic phase can be very, very brief. That I might miss it, or the parent might miss it, but the EEG will show it or will prove it to me. So having just the myoclonic without the tonic phase makes me think less likely spasms. The other piece to it, and that depends on the age. If it's a neonate, it is unlikely for a generalized, quote unquote, myoclonic event to be epileptic in nature. Like we agreed, the babies don't have that myelination, don't have that networking to mount a generalized seizure. In older children, having that back history, like we agreed, in older children, typically the spasms will happen in cluster. Myoclonic seizures, even if it happens in cluster, the cluster and pattern will be different. It's not going to be that back to back to back to back. So I might have like every 5 or every 10 seconds spasms, as opposed to the myoclonic. It's going to be random. I'm going to have like 15 in a row, then wait like 30 minutes and have another 2, then another 2 hours, and I have like 7. It's going to be very random cluster of the myoclonic, as opposed to the spasm. It's a lot more rhythmic. I can predict, I can expect when that spasm will have. So I hope that answers that question.
Actually, I've seen many patients with infantile spasm that do not have typically the tonic phase, and even you can see the decrement as clear as you were mentioning. I know it's not like a textbook description.
And
but anyway, I agree with you. Thank you.
Yeah, no, but you're right. You're absolutely right. And that's why, and again, I have to go back to the EEG and look at what my EEG shows, because you're, like I mentioned, so the spasm has two phases to it, myoclonic / tonic. I sometimes will see a very pronounced myoclonic and very diminished or not easy to detect tonic form. So it's more of a myoclonic. Some other times it's the tonic is actually the one that's very clear. So the jump happens very briefly, but it's going to be that brief tonic. And as babies with epileptic spasm, or as children with epileptic spasm start to transition over to Lennox-Gastaut, which we know that about 75% of them will transition over to Lennox-Gastaut, they will change that form from the spasm to brief tonic seizure. And that's where sometimes the confusion even will be. Is that a brief tonic or is that a spasm? And that's when we have to rely on the timing of that seizure.
Can I ask one question? Sorry, I forgot to ask about the infant spasm. What's your practice when you start the patients on the prednisolone UCAS protocol or the vigabatrin or both of them according to the new guidelines? And if you have a patient, because this is, I've seen it at least for the 5 patients over the past year, and they have received the UCAS protocol and with the vigabatrin and they relapsed. So how many times can you repeat the UCAS protocol, and in how short you actually can initiate this, especially if there is no accessibility to ketogenic diet or these options are not available? I know it's a difficult question, but please.
It is. And, you know, I wish I have a magic answer. But like you said, so yes, we do repeat the protocol again. But after that, we actually start looking at some other options or other treatments. There's some non-FDA approved treatments, clobazam, Epidiolex, which is CBD, because typically by that time, I look very, very carefully for other seizure types besides the spasms. Most kids, not all kids, but most kids, as they fail the second round of the protocol, they start developing some other seizure types, either brief tonic seizures, or they might have some atypical absence, or they might have some other focal seizure types. And that's what will transition them from the epileptic spasm phase to the Lennox-Gastaut phase. And that's what opens some other treatment options to me. But yes, those are the very challenging children. But also, and I know we didn't talk about it here, but when we talk about the drug-resistant epilepsy protocols, it's pretty clear. Past my third medicine, and I can repeat, especially in spasm, I can repeat the protocol. I need to start thinking out of the box. I need to look at, can this be a resection? And the paper that I showed you that we published with 7 cases, number of them actually had spasms. One of them I remember very clearly had an AVM, believe it or not, and that presented with spasms. On the EEG was showing your typical hypsarrhythmia, your typical spasm-like, yet this was because of an AVM. So resecting that AVM or taking care of the AVM helps resolve the seizure. So that's early on. We've had kids that we implanted with VNS for spasms. We've had kids that obviously with ketogenic diet. So I go down the drug-resistant algorithm if my second round for the spasms didn't work. I want to make sure that I address your question about the pyroxene deficiency or dependency. So typically, that's a diagnosis of exclusion, meaning that after, like, the kid is failing to respond to the first or second medicine or third medicine at times, we'll always do the pyroxene dose with EEG running, and you'll see one of 3 things. Either you'll see the EEG immediately normalizing or getting significantly better, and here's your diagnosis / treatment. Sometimes you see an improvement, but you're not really sure, and that's why you continue it for at least 48 hours, because there, as you know, there are late responders. And sometimes you're not going to see any improvement. In that case, I will still keep him on for about a week and see clinically if there's any improvement. I understand sometimes it's a little challenging to get the EEG. In our case, 100% of the pyroxene has to happen with an EEG. So I do the infusion while the EEG is running to document what's going on with the EEG. But if EEG is I don't have it available, it's going to be a week until I get it, then I think it's appropriate to go ahead and empirically treat, and usually can do 100 to 150 milligrams, and then you maintain them on it for a few days and look for the clinical response.
Thank you very much, Dr. Ahmed. It was really a great pleasure having you with us today. And because of the time, there is no more question. We are going to move to the next speaker. Our next speaker is Professor Dr. Anita Devlin. I have the pleasure to introduce Dr. Anita. She is a consultant pediatric neurologist specializing in epilepsy, vagal nerve stimulation, and neurodisability. And Dr. Anita will speak about seizure semiology in children.
While we're getting set up, I'd like to thank Okay. So good afternoon, everyone. I'd like to thank Dr. Omnia El-Rashidi and the Egypt Specialized Society of Pediatric Neurology for inviting me to speak today. It's a great honor to be here. I never thought, though, I would be cold in Cairo, and I've been sitting there waiting to come up.